Hello and welcome back to Week 8 lecture. I'm Dr. Varela and I'm glad to have you here with me today. So today we're going to be talking about local anesthetic complications and medical legal considerations. And some of those complications that we'll be covering include the very important topic of needle breakages. Now we've touched upon this topic a little bit in the past, but we're really going to dig deep into this topic and go into a lot more detail about it. We're also going to go over a few other local anesthetic complications, and some of those include prolonged anesthesia, facial nerve paralysis, trismus, soft tissue injury, hematomas, and we're going to talk about what happens when a patient feels pain or burning on injection. What happens if the patient starts to develop an infection, or starts to develop edema or sloughing of tissue, or even an oral lesion related to the delivery of local anesthetics. We're also going to be covering the important topic of medical legal responsibility, and the considerations you should have when giving local anesthetic injections. So let's go ahead and get started. Now, first on the list is needle breakages, and since the advent of the disposable needle, these have become extremely rare. But of the needle breakages that have occurred, 98% of these cases involved a 30 gauge needle. Now, you'll remember from our previous discussion about the gauge of a needle that when we talk about the number going higher, so a 30 gauge needle, as opposed to a 27 gauge needle, the 30 gauge needle is going to be a lot thinner because of the smaller lumen diameter. A 27 gauge needle is going to be thicker relative to a 30 gauge needle because of the increased lumen diameter. And you'll remember that confusing relationship between gauge number and actual thickness of the needle. Now, more than 90% of these cases involved the inferior alveolar nerve block, which should also communicate something very important to you, that long spans of tissue can be a trigger for a lot of these needle breakages. So the information that you should really kind of take away from this is that smaller, thinner needles in areas where long spans of tissue have to be traversed are really kind of the perfect storm in creating this risk of needle breakages. And really, if you think about the inferior alveolar nerve block, it's really one of the few local anesthetic injection techniques that really requires you to traverse a long span of tissue to be able to give to be able to provide anesthesia. And so it's really important that you know some of that you be reminded of some of the anatomy of the area. So when we give an inferior alveolar nerve block, we're really kind of aiming for the lingula, which is on the medial aspect of the mandible. And this lingula is essentially a projection of bone that covers the entry of the inferior alveolar nerve into the mandible. And this is all contained within a fascial space known as the pterygomandibular space. Now, in this space, we have the lateral pterygoid muscles, and we also have those lateral pterygoid muscles that are positioned superiorly. And the medial pterygoid muscle is positioned medially. Now, these two muscles are muscles of mastication, and along with all of the other soft and hard tissue structures in the area, they really kind of provide this tension, this soft tissue tension that's really capable of breaking the needle away from the hub, particularly if you're using a thin needle or a very thin gauge needle like a 30 gauge needle. Now, if a needle is buried all the way to the hub, then there's a really increased likelihood of that occurring, it may not be so it may not be so possible for the needle to separate if you bury it, let's say halfway. And the reason for that is because there's no point of attachment halfway up the needle. There is a point of attachment when you're all the way to the hub, because that's where the needle attaches to the main plastic housing, which we know as the hub. And so if you bury the needle all the way to the hub, and what I mean by that is that you insert the needle all the way until the white plastic hits the soft tissue, then the likelihood of experiencing a needle breakage is very, very high. A lot of times what ends up occurring is that you bury the needle all the way to the hub, and there may not really be an opportunity for you to know that the needle is broken until it's too late. So what do you do if a needle breaks while you're using it on a patient? Well, first and foremost, you have to stay calm and you have to stay where you are. Do not get up to go look for your attending. You stay where you are. The worst thing you can do is panic. And the second worst thing you can do is walk away, because what you could do is miss a very important opportunity to retrieve the needle. So again, stay calm, stay where you are, and try to keep the patient still. And as you're trying to keep the patient still, look inside their mouth where you inserted the needle and see if you can see the metal of the needle sticking out from the soft tissue. Now, if any part of the needle is visible, then what you'll want to do is place a really large piece of gauze at the back of the throat and retrieve the needle fragment with a pair of hemostats or even cotton pliers. Now, the reason why you want to use a throat pack is because if you do happen to pull that needle out, you don't want it to then fall down the back of the throat, because then that would be another nightmare that you'd have to deal with. So if you can see the needle and if it's easily retrievable, do so by using hemostats or cotton pliers. Hemostats are preferable because you can lock them in place. Cotton pliers, you can't always lock them in place. Make sure that when you are trying to retrieve the needle, do not push the needle further in, because then that makes it even more difficult to retrieve the needle afterwards. Now, if the needle doesn't move and appears to be stuck, then lock the hemostats onto the needle fragment and then have someone go get an attending for you. Do not leave the patient alone. Oral surgery should be contacted immediately at this point, and you should kind of be the person to explain everything that's occurred. Now, what do you do if the needle breaks and it's not visible? Well, you want to inform the patient of what has occurred and instruct them to remain as still as possible. And this is because any muscle movement can cause the needle to migrate. Have someone go and get the attending for you and go and get somebody from oral surgery to come over immediately. Again, do not leave your patient. The things you want to remember are, first, stay calm, stay where you are, keep the patient still, and have someone go and get an attending and an oral surgeon as soon as possible. If the needle is visible and retrievable, then please attempt to do so with a hemostat if it's available, or cotton pliers if they are available, making sure to always utilize a throat pack or a large piece of gauze at the back of the throat. Do not use small gauze. The 2x2 gauze are too small and can be easily swallowed by the patient, and so you want to use like a 3x3 or a 4x4 gauze in these types of situations. But overall, just stay calm and keep the patient still. So this series of pictures here shows how this needle kind of migrated to a different point. So if we start here, you can see that the needle, this is probably where it was originally inserted and broke off. But due to the patient's just kind of the native movement of the soft tissue, muscular tension, the pumping of blood vessels, and things like that, or the patient's swallowing reflex, that needle very quickly migrated to a different location other than the original point of insertion. What happens when this occurs? Well, when the needle starts to migrate, it gets a little bit more difficult, and the patient has to have exploratory surgery to try to retrieve that needle. A lot of things can happen during this time. A lot of damage can occur, not only to soft tissues, but nerves and blood vessels. So, how do you prevent situations like this? First, I'm going to give you a long list of nevers, okay? And these things should never, ever be done. Never use a short needle for an inferior alveolar nerve block. Second, never use a 30 gauge needle for an inferior alveolar nerve block. And remember, the 30 gauge needle is typically the short needle that we use. It's much thinner and much more likely to break. Never bend the needle at the hub. And that should hopefully go without saying. The next one, never use the soft tissues to bend the needle. And this really kind of refers to a situation where you feel like maybe your needle tip is not where it should be, and so maybe you nudge that needle while it's still in place, just to move that needle tip just a couple of millimeters. And you should never do that, because essentially what you're doing is you are using that soft tissue, hard tissue, and muscle tension to really kind of bend the needle, and the likelihood of it breaking at that point, and especially with the aggressive way that you're using the needle, really increases the risk of a needle breakage. You also want to be really cautious when dealing with patients that have a lot of anxiety, or maybe they're a little fidgety, or maybe they even have a situation where they've got Parkinson's disease or involuntary movements, because that increases the likelihood of needle breakages as well. I think we can all agree with the fact that if you have this needle and you're trying to insert it into a moving target, the likelihood of it breaking once you get into the soft tissue, but there's still movement in the head and neck area, it increases quite a bit. So just be really careful when you're dealing with kids and patients that have a lot of anxiety and maybe even some tremors or anything like that. So that is the topic of needle breakages, and we're going to move on to the next topic, which refers to paresthesia, or some other type of altered sensation. Now, paresthesia refers to kind of a burning, prickly sensation in the affected area. Prolonged anesthesia can also be another situation that can occur with respect to the administration of local anesthetic. And prolonged anesthesia really kind of refers to this situation where anesthesia that really kind of persists beyond what is the time frame that's originally expected. Now, it is normal and expected for anesthesia or even some paresthesia to be present for several hours following the initial injection, but it's not normal for these conditions to persist for days, weeks, or even months. Now, patients might complain, patients might complain of burning, of having a prickly sensation, or they may even complain of a loss of taste, or even might start to develop a speech impediment. Now, complications such as these are really kind of typically caused by some sort of mechanical trauma, but it can also be caused by contamination of the local anesthetic through alcohol. The way that you'll know if a patient has paresthesia is that they'll usually return after several days or weeks following a procedure and report that they are still numb, or that they have kind of this burning and tingling sensation that just hasn't gone away. And how do you manage that? Well, first and foremost, you want to reassure the patient. Paresthesias usually resolve on their own within about 8 weeks. Make sure that you go out of your way to see that the patient is doing well. Give them a phone call. Make sure that you're making contact with that patient on a daily basis, and you want to make sure that if the patient shows up to your office, do everything that you need to do to see that patient. These are really not the patients that you want to lose patience with or treat like a nuisance. You want to make sure that you bend over backwards for these patients to make sure that you're constantly reassuring them and that you're constantly evaluating the situation. So examine the patient in person and schedule them for reevaluation every 2 months as long as the sensory deficit persists. Um, Really, it should go without saying that you should keep an outstanding medical legal record of all of your interactions with this patient and contact your liability insurance carrier and inform them of the situation if it persists more than a month or two. Now, a lot of times when you bring them into the dental office, what you'll do is that you will track exactly where the altered sensation is on their mouth. So let's say, for example, that you have given an injection and that they are reporting an altered sensation in a certain area. And the way that I like to do it is I like to take a cotton-tipped applicator, and I like to first do kind of a soft stroke with the cotton-tipped applicator over the area that the patient is indicating. And then I like to use some sort of marker that can be easily washed to kind of map out the area where the patient is feeling that altered sensation. And then you take a picture of it and keep that for your record. And then each time that the patient comes in, you remap the area to kind of see if it's shrinking or staying the same. And usually I document what type of sensation, whether it's a burning, prickly sensation. Sometimes people describe it as kind of ants crawling all over your skin, just kind of that prickly sensation, or if it's some just numbness. I did have this occur with a patient, not in relation to local anesthetic that I had given, but this was a situation where the patient had used a chemical in their mouth that caused a little bit of nerve damage. And so the patient came to me to figure out what was going on, and we did this exact same thing. We kind of mapped out the location. I had the patient back a few times to kind of check on the progress. We even gave them a little bit of a steroid to see if perhaps the nerve damage was really just kind of due to inflammation. And it took quite a while for this patient to heal from this event. But eventually, one of two things happen with these types of patients. Either they get acclimated to this new form of sensation, or the sensation returns. And so we want to put the patient in a mental state where they are prepared, their expectations are prepared to either be able to adjust to this new situation with altered sensation as kind of a permanent part of their life, or you want to explain to the patient that this has a good likelihood of healing on its own. And so a lot of times, sometimes it does heal on its own, and sometimes it doesn't heal, and the patient just eventually gets used to it. But you want to be very sensitive with these patients, and don't treat them poorly. You want to make sure that you're constantly in communication with them, and show a great amount of empathy, because it really can be very bothersome and interfering to have this sort of situation happen. So be very sensitive and compassionate with these patients. Next on the list is facial paralysis, or what we call in the business transient Bell's palsy. Now, this occurs when local anesthetic is administered into or near the parotid gland, which contains the facial nerve trunk. Now, how does one accomplish such a monumentally idiotic feat, you might ask? Well, one of the attempts, and I'm only saying idiotic because this has occurred in my past, and this actually happened to me when I was a dental student. But what happens is that typically, if you're trying to give an inferior alveolar nerve block, and your needle goes a little bit too deep, and goes past the angle of the mandible, it can kind of go into the parotid gland territory. And then you start giving a little bit of local anesthetic there, and it can cause those nerves to kind of stop working for a little while. And then what ends up happening is that the patient really kind of loses muscle tone on that affected side. Now, you'll immediately see the effects of this because it will present essentially as facial drooping on that affected side. And you'll know that facial drooping is kind of what we see in patients that might be experiencing a stroke. So what do you do if this happens to your patient? First and foremost, reassure them and let them know that what has occurred, and a good way to kind of talk about this situation is by using messages like, I just wanted to let you know that some of the local anesthetic has traveled to the nerve that kind of controls those muscles in your face, and you might notice a little bit of drooping on that side of your face. And this is kind of a transient situation, and it really should resolve within a few hours. And some of the really important things to consider for this situation would be, if the patient is wearing contacts, make sure that they remove them, because what happens is that a lot of times the patients can't close their eyelid, and so their eye dries out, and then those contacts can kind of cause some corneal abrasion. Now, this is really important, because if this happens to if it happens to you and it's kind of lasting for a little bit longer than we'd like, we start to tell the patient to maybe wear an eye patch, just to kind of protect their eye from any kind of abrasive. Be sure to record the incident in the patient's chart. Always make sure that you record the fact that you have communicated this incident to the patient. And really just be very careful. How do you avoid this complication? The hallmark of an appropriately administered IA block is that you've hit bone. And if you haven't hit bone, and it looks like you're about to go more than 3/4 of the length of the needle, you need to retract the needle and reinsert. If you're just really not sure that you're doing this correctly, get an attending to come over and help you with this injection technique. You're here in school to learn how to do this properly, so don't be afraid or embarrassed to ask for help. The way that we teach doing the inferior alveolar nerve block here includes a couple of different things. First, you never use a short needle, and we talked about this a little earlier. Secondly, you always want to make sure that your needle hits bone. Okay. Remember when we talked about the inferior alveolar nerve block in a previous lecture, we talked about how do you know where you are. If you insert the needle and it almost immediately hits bone, you're too far forward or anterior. If you insert the needle and the needle just keeps going and going and going into the soft tissue and it hasn't hit bone, you're too far backwards, or posterior. So the sweet spot is that you want to be able to be the needle halfway into the soft tissue and you've already hit bone, and that's kind of the sweet spot. And so if you're not, and you just keep going and going and going, you're risking an accidental facial nerve paralysis. Retract the needle and try again. Again, don't be afraid to ask for help in the clinic. This is what you're here for. Now here we have a picture of a patient with facial nerve paralysis. Notice how on the left side of her face there's a lot of muscle flexicity, and look how she's unable to close her eye. Okay. On the left side on her left side of the face, you can see on this picture here that she can close the right side of her face, but the left side of her face is unable to be closed. And so you just really this is a really good tool to use in being able to evaluate whether a patient has muscle facial muscle nerve paralysis. So, all right. The next topic is trismus, and trismus is characterized really by kind of a tetanic spasm of the jaw muscles that really kind of restricts the patient's ability to open their mouth. And this is sometimes referred to as lockjaw. And trismus, related to local anesthesia, usually improves after about 48 to 72 hours. Now, trismus occurs when there is trauma to the muscle or blood vessels in the infratemporal fossa. Now, it can also be caused by alcohol-tainted local anesthetic. So how do you manage trismus? Well, you want to begin by examining the patient's ability to open. You want to advise the patient to begin with some heat therapy and warm salt water rinses. And analgesics such as ibuprofen and Tylenol can be used for pain management as well. Now, if necessary, you can prescribe a muscle relaxant, but this should be some of the more intermediate steps. Instruct the patient to start practicing opening and closing their mouth, as well as going through lateral excursive movements for about 5 minutes every 3 to 4 hours. You can also have the patient start to try to chew gum to help them in performing a lot of those lateral excursive movements. Now, if worse comes to worse, you can perform an Akinosi block to help alleviate muscle tonicity and help the patient open their mouth. And we talked a little bit about the Akinosi block previously, and it's the preferred block if a patient does have trismus, which basically means they can't open their mouth. They've got this limited opening. Now, as always, be sure to record this in the patient's chart. Now, how can situations like this be prevented? Well, trismus isn't always preventable. A lot of times when trismus occurs secondary to some other condition, there's nothing really that you can do. You can avoid trismus-related situations as they relate to local anesthetics, but with trismus being caused by other things, there's not really a whole lot you can do to prevent that. But what you can do is that you can lower the risk by using a sharp, sterile needle and handling the anesthetic cartridges with a lot of care. Make sure that there's no alcohol that contaminates the local anesthetic, and you can also avoid this situation by using aseptic technique, which basically means that you dispose of contaminated needles as soon as possible. Try to practice atraumatic insertion. And try to do the best that you can to be as precise in your insertion technique as possible. This might include things such as avoiding repeating injections or multiple insertions into the same area, and this really kind of goes back to knowing your anatomy and knowing where it is that you're inserting that needle. Don't use more volume of local anesthetic than you need to, and administer nerve blocks whenever possible. Next on the list is the topic of soft tissue injury. Now, this usually happens because the patient is numb and they don't know that they're chewing on their lip or their cheek or their tongue. And you can manage it by advising the patient to take analgesics for the pain and prescribe them antibiotics if the injury becomes infected. Warm saltwater rinses may help to reduce some of the swelling, but you can also have them put Vaseline on their lips to help minimize the irritation. This happens occasionally, but it can be prevented. And some of the steps that you can take to prevent this type of situation are first to use a local anesthetic that has the appropriate duration. You don't want to use something that's going to be on board for a really, really long time when you don't need to. You also want to warn the patient or even the parent if it's a child, if the patient is a child, to avoid eating, to avoid drinking hot fluids, and to avoid doing anything that might increase the risk of them chewing on their cheek, their lip, or their tongue while they're numb. I typically inform my patients that it's recommended that they avoid eating for the next couple of hours after I'm done with the procedure. This helps the patient to understand what the expectations are, and I always record this in the patient's record as well, that postoperative instructions have been given. Another really great option is, especially with patients who are pediatric patients or even patients that have some sort of developmental disability and their cognitive function isn't very good. They might have a caregiver with them, is to use these stickers. And these stickers help to remind the patient and the parents or caregivers that the patient is still numb and that they should avoid doing anything that might cause soft tissue injury. The next item on the list is hematoma. Now, a hematoma occurs when a blood vessel is inadvertently damaged during local anesthetic administration. These tend to get pretty big, pretty fast, and they can occur really more often when an artery is nicked rather than a vein. Now, the tissue density around the vessel is also kind of a determining factor in how large this gets. But if you have more dense tissues, such as the palate, hematoma is really kind of less likely to develop. And that's because the tissue is so dense around there and it's so firmly adhered to the bone that it's less likely to allow the blood to kind of expand the area and cause a hematoma to form. Now, these typically resolve between a week and 2 weeks. And the way that you manage it really involves applying direct pressure to the area that's bleeding. So for an IA block, you want to press on the medial aspect of the ramus. For an ASA, for example, you want to press on the skin over the infraorbital foramen. For incisive or mental nerve blocks, you want to press on the mental foramen intraorally or even extraorally. For buccal or palatal, you want to press on the site of bleeding. Now, for the PSA, it's a little difficult to apply pressure anywhere. And so sometimes when you do have situations that involve the PSA, the hematoma may just occur, and there's not a whole lot that can be done. Now, an important point is to avoid applying heat to the site of bleeding. Now, hopefully you understand why, because heat will increase the blood flow to the area that it's applied to. Now, instead of applying heat, you can apply some cold or ice as soon as you're aware that the hematoma is forming, and avoid doing any more dentistry in that area until that resolves. Next on the list is pain on injection. Now, this is a completely avoidable situation, and this particular type of complication is caused by careless or callous administration of local anesthetic. It basically occurs when the operator is really just kind of being careless and rapidly deposits the local anesthetic. And the best way to manage this is to really have a listening attitude. Listen to your patient. Don't be callous or unfeeling. Really, beyond that, there's really no other management that needs to be done. You need to have a soft hand when you're giving local anesthetic injections. You need to have a listening ear, and it's always really important to give that patient a sense of control, because most patients, what they're really fearing is the injection. Prevention really can also involve using topical anesthetics and using a sharp needle and injecting slowly. Now, other things that may affect pain on injection include if the solution is too hot or too cold, but the main point here is to be very soft and inject slowly. On a similar note is burning on injection, and this is really caused more by the speed of injection. The main point here is to inject slowly. There's some gadgets on the market that will that might help in other aspects. Sometimes other things that can cause burning sensation on injection, other than injecting too fast, can be if the local anesthetic solution is too cold. And there are some gadgets that help to warm the local anesthetics to a near body temperature. So it kind of makes it a little bit more comfortable for the patients. Um, but sometimes those warmers um, can actually make it too hot, and can actually make the injection just as uncomfortable for the patient. So what I like to do is, if the local anesthetic has been sitting out in a little cupboard, or if it's been sitting out in a little container ready to be used, I usually just warm it up with my hands, and then put it up load it into the syringe, and then use it for an injection. So, there's quite a bit of control that you can have over the experience that the patient has with local anesthetic injections. And so, similarly to what we just talked about with pain on injection, you want to be very cognizant of what the patient is feeling, constantly communicating with the patient, and make sure that you're using a soft hand, and communicating with the patient. The next complication is an infection. Now, infections, as they relate to local anesthetic injections, occur when you deposit the needle into an infected area, such as an abscess, and then use that same needle in a different area of the mouth. Now, what you essentially are doing is seeding bacteria into healthy tissue. Now, as you know, injecting into an infected area renders the local anesthetic less effective. So how do you get around this? Well, if the infection is bad enough, you want to start by anesthetizing with one needle, and then changing it out if you have to insert it into an infected area. If you have to go into a different area, change it out for a new needle, and also change out the carpule as well, so that you're starting with a sterile needle and a sterile carpule. Now, some of the things that you can do to help the local anesthetic to actually work in areas of infection is that you want to try to maybe anesthetize some of the tissue that is overlying the infected area, and then possibly do an incision and drainage. Now, the incision and drainage can only be used in certain situations, so make sure that you talk to your attending about whether that approach is appropriate. Now, as you may have guessed, the best way to prevent this is by using a sterile needle and not using a contaminated needle in healthy tissue. And this can really occur in the same patient. It doesn't mean that you're using a used needle, right? What it means is basically that you're going into an infected area with a needle, and then taking that needle into a completely healthy area. And so what you want to do, like I said before, is that you want to make sure that you change out the needle and the carpule, so that if you do use it in an infected area and you change it out, you're basically using a brand new sterile needle and carpule to inject into a healthy area of tissue. Next is edema. Now, edema can occur because of some sort of allergic reaction or adverse reaction to a component in the local anesthetic. And it can be potentially life-threatening, now, especially if the airway becomes compromised, because if the airway becomes compromised, the patient can't breathe, and immediate life support will be needed. The first step in managing a situation like this is to activate the emergency medical system. Clinical management involves administering 0.3 milligrams of epinephrine, or in other words, 0.3 milliliters of a 1 to 1,000 epi solution for an adult, and 0.15 milligrams or 0.15 mils of a 1,000 milliliter solution for a child. And this typically means a child between 15 to 30 kilograms. Now this can be delivered intramuscularly. A 3 milliliter solution of a 1 to 10,000 epi can also be administered intravenously. Now this has to be done every 5 minutes until respiratory distress is resolved. Now if total obstruction of the airway is identified, a cricothyroidotomy might need to be performed to allow that patient to breathe. But what's essential here in this type of a situation, other than all these facts and figures, is to activate the emergency system that we have in place here at the school. And signs for that emergency system can be found on the clinic floor. You really just want to get that patient help as fast as you possibly can. We have emergency kits available. If it is appropriate for that patient to receive epinephrine to help open up their airway, then that needs to be determined and done as quickly as possible. But you want to get as many people as you possibly can into action by activating our emergency system. Now, really the best way to prevent this situation is to perform a very thorough medical evaluation, going through the patient's medical history prior to administering any drug to this patient. And so, getting an accurate and complete medical history is a must. Sloughing of tissues is another complication caused by prolonged irritation or ischemia of soft tissues. Now, this can also be an indication of epithelial desquamation and a sterile abscess. Now, this occurs when anesthetic is left on the epithelium for too long, and this causes the tissues to start to slough off. A sterile abscess occurs when the area you have anesthetized becomes ischemic because you've completely cut off all the blood supply to the area. And this usually occurs on the hard palate. Managing it involves reassuring the patient and informing them of how this occurs. Analgesics can be used to help treat the pain, and you can prevent this from occurring by using local anesthetics and topical anesthetics as directed. In other words, don't leave a topical anesthetic on the tissues for more than a minute. Also, avoid using highly concentrated solutions of epinephrine, and know your anatomy. The palate is the most common place for this to occur. And another thing that you want to avoid doing is injecting too quickly. If you're giving a greater palatine nerve block and you're injecting that faster than 1 milliliter per minute, then what ends up happening is that you are changing the fluid pressure of that area that has very little flexibility in a very short amount of time, which basically puts stress on a lot of the pressure sensors in that area, and can also completely cut off the blood supply and therefore form one of these lesions. So be very careful about how you administer local anesthetic. Make sure that you're administering slowly at 1 ml per minute, and also make sure that you are using the correct local anesthetic and know your anatomy. Now, from a medical legal standpoint, every interaction that you have with a patient must be documented in that patient's chart. In general terms, if you did not document it, for example, your management of a critical situation, it's as if you never managed it at all from a legal standpoint. You need to understand that the patient's chart and your documentation notes are essentially a legal record of your interaction with that patient, and as such should be as accurate and complete as possible. Now, as it relates to recording your use of local anesthetics, 5 very important things should always be included in that patient's chart. The first is the use of topical anesthetic. The second is the type of local anesthetic that was used. The third is the amount of local anesthetic. The fourth is the type of needle that was used. And the fifth is the injection type that was administered. Now, an example of what this should look like in your patient's chart should be something like this. Topical anesthetic placed. via inferior alveolar nerve block and local infiltration, 2 carpules of 2% lidocaine, 1 to 100,000 epinephrine, administered using a 27 gauge long needle. Now finally, I'm going to introduce you to some terms that you should be familiar with, and they really describe your medical legal responsibility to patients. Generally, a duty is created when a patient and a doctor interact for healthcare purposes. So as a doctor, you have a duty to the patient if your conduct created a foreseeable risk to the patient, which providing any form of healthcare does. A breach of duty occurs when the healthcare professional fails to act as a reasonable healthcare provider. And this, in medical or dental malpractice cases, is provided to the jury by comparison of the defendant's conduct with the reasonable conduct of a similarly situated health professional. In other words, you get compared with your peers. What are your peers doing? And are you doing the same thing that your peers are doing? Proximate cause is the summation of actual cause and legal cause. Now, actual cause exists if a chain of events factually flows from the defendant's conduct to the plaintiff's injury. Legal cause is present if actual cause exists, and if the plaintiff's attorney can prove that the harm sustained was foreseeable or was not highly extraordinary in hindsight. Damage is the element of the cause of action that usually is most easy to identify because it's the most often manifested physically. Now, simply because damage is present does not mean that malpractice has been committed, but damage must be present to fulfill all the elements of the wrongful act. And finally, consent. Now, the consent process is an essential part of patient treatment for healthcare professionals. Essentially, consent involves explaining to the patient the advantages and disadvantages of differing treatment options, including the benefits and risk of no treatment at all. Often, treatment planning will result in several viable options that may be recommended by the doctor to the patient. And the patient makes an informed decision as to which option is most preferable to them, and then treatment can begin once the patient consents. Consent is essential because many of the procedures that doctors perform would otherwise be considered illegal, right, if the doctor was not licensed to do so. And consent may be verbal or written, but when a controversy presents at a later date, a written consent is extremely more beneficial. In fact, because many times consent is required to fulfill the standard of care for a procedure, lack of written consent may reduce the fact-finding to a he said or she said scenario. So the circumstance may greatly diminish the plaintiff's burden of proving the allegation and may even shift the burden of proof to the defendant. Now, when the mentally challenged or children younger than the age of majority are treated, consent from a legal guardian is necessary for elective procedures. Whenever restraint is planned or anticipated, consent is then warranted. Now, I hope that you learned a lot from this semester, and I hope that you learned a lot from this lecture. There is one other part of this week's module that you'll need to look at, and that is the information that's being presented by Professor Dixon with respect to ORAKIX. I hope that you've enjoyed this course and this semester. Please don't forget to share one thing that you learned, and also don't forget to take your quiz this week. And hopefully we'll see you down in the clinic next time. Thank you.